We're diving straight into the clinical trenches today with a text that, honestly, it kind of fundamentally changes how you look at patient diagnostics.
Oh, absolutely.
Yeah, we're unpacking the third edition of a really renowned book, 150 Problemas, the ECG, by Dr. John R. Hampton. He's the Emeritus Professor of Cardiology at the University of Nottingham.
Right. And for all the medical students, the residents, and, the clinical learners joining us today, you should really consider this deep dive a sort of master class.
Exactly.
We're taking all that dense textbook cardiology and translating it into actual, actionable bedside knowledge.
Because the overarching mission of this book, the whole point of it, is to bridge that gap between, theoretical electrophysiology and the actual living, breathing, often highly unpredictable human being sitting right there on your exam table.
Yeah, Dr. Hampton basically makes the argument that, sure, mastering the foundational books is completely necessary, but the clinical reality is, well, it's vastly more nuanced than that.
It's such a fascinating premise because I feel like in medicine, we naturally crave objective precision.
Oh, for sure. We want a clear answer.
Right. Like if a patient comes in with trauma to the forearm, you order an X-ray.
Yeah.
You see the jagged white line through the radius, and boom, you have your fracture. It's visual, it's structural, it is definitive.
Yeah, but then you step into the cardiovascular realm.
Exactly. You print out a 12-lead ECG,
Yeah.
and suddenly you are looking at a diagnostic landscape that is just incredibly murky. I mean, it's just a two-dimensional representation of electrical vectors.
And those squiggly lines are, they're never just black and white.
No. They require interpretation entirely through the lens of the patient's presentation. You just cannot separate the paper from the person.
You really can't. I mean, the ECG is a phenomenal tool, right? It gives us this rapid, non-invasive look at the heart's electrical conduction system.
Yeah, which is amazing.
It is. But relying on it without the clinical context is a really dangerous game. And that brings us to Hampton's golden rule for this whole deep dive, which is that the patient's history and their physical exam, those always have to dictate your interpretation of the tracing, not the other way around.
Right. So let's test that rule with a scenario that pretty much every clinician dreads.
Okay, let's hear it.
So a patient presents to the emergency department, and they have a highly convincing history of an acute myocardial infarction.
The classic presentation.
Right. They have that heavy radiating ischemic pain. They're sweating diaphoresis, the whole clinical picture.
Okay.
You run the ECG in that first hour, and it is completely pristine. I mean, normal sinus rhythm, no ST segment deviation, completely normal T waves.
So it looks perfect on paper.
Exactly. And the temptation for a busy, maybe overworked clinician might be to look at that normal tracing, feel a false sense of security, and just consider discharging them.
But doing that would be completely ignoring the actual underlying pathophysiology of ischemia. Because if you're listening to this and wondering, wait, how can actively dying heart muscle fail to register on an ECG? Well, you have to look at the timeline of cellular injury.
Because it's not instantaneous.
No, not at all. The ECG is measuring electrical gradients across cell membranes. So when a coronary artery occludes, the myocardium distal to that blockage becomes hypoxic. It's starving for oxygen.
Right.
But it takes time for that lack of oxygen to actually deplete the cellular ATP stores.
Yeah.
And until those energy stores are fully depleted, the sodium-potassium pumps on the cells, they just keep working. And so the resting membrane potential remains relatively stable.
Wow. Okay. So the electrical signature literally hasn't changed yet because the cellular machinery hasn't completely failed, even though the tissue itself is screaming for oxygen.
You captured the mechanical timeline perfectly there. I mean, the ST segment elevation that we always look for, that only occurs after the transmembrane potential alters enough to create an actual current of injury.
Oh, I see.
Yeah, so in those early hours, the tissue is definitely ischemic, but the electrical gradient hasn't shifted yet.
Which is terrifying, honestly.
It is, and this is exactly why a normal ECG, in the face of really strong clinical suspicion, means absolutely nothing.
So you admit them.
Always. You have to admit the patient, observe them, perform serial ECGs, and crucially, track their plasma troponin levels.
Because the troponins give you that biochemical proof.
Right.
Like proof of myocardial necrosis, way before the electrical vectors have time to catch up and change.
Exactly.
It's kind of like trying to drive a car by only looking at the dashboard gauges and totally ignoring the windshield.
That is a great analogy.
Like you could look down and see you have a full tank of gas, the engine temp is fine, but you could literally still be driving off a cliff.
Yeah, the ECG is essentially just a trailing indicator in that specific early window.
Right.
And, Dr. Hampton also applies this exact same logic to heart failure.
Oh.
Yeah. He notes that while an ECG can show you signs of prior insults, like, say, pathological Q waves from an old infarct, it cannot definitively prove mechanical failure.
Because it's just electricity.
Exactly. It's primarily a tool for ruling out pathology in this context. If the ECG is completely normal, then significant heart failure is highly unlikely. But an abnormal ECG doesn't just automatically confirm it.
Because, again, it measures electricity, not ejection fraction.
Right.
So if we take this concept that a normal ECG doesn't guarantee a healthy patient, and we flip it, we arrive at another one of Hampton's core lessons, right?
Yes.
That an abnormal-looking ECG does not automatically dictate the presence of an actual disease.
Which perfectly explains the really unique structure of his book.
Yeah, I love how he organized it.
It's so good. He doesn't group the 150 cases by pathology, like putting all the bundle branch blocks neatly in Chapter 4 and then all the tachycardias in Chapter 5.
Right, which is how every other textbook does it.
Exactly. Instead, he presents them completely randomly.
Because that's what the clinic is like.
Yes. The clinical environment does not sort your patients by difficulty or by anatomical system. The triage nurse doesn't send you a really simple sinus arrhythmia, followed neatly by a complex AV block.
You just never know what's coming through the door.
You have to be prepared to interpret whatever prints out in real time. And a massive part of that is recognizing physiological adaptations that are essentially masquerading as pathology.
Okay, yeah. Like the voltage criteria for left ventricular hypertrophy,
Right.
or LVH, that is a perfect example of it.
It really is.
Because you look at the precordial leads, right? And the S wave in V1 plus the R wave in V5 is, say, well over 35 millimeters.
Huge spikes.
Massive spikes. On paper, it absolutely meets the textbook Sokolow-Lyon criteria for LVH.
Sure does.
But Hampton argues, if this tracing belongs to, like, a 20-year-old, totally asymptomatic university student who is thin and active, this is highly likely just a normal variant.
Right.
But what is the actual physical mechanism driving that massive voltage on the paper if the heart muscle isn't actually hypertrophied?
Well, it really just comes down to basic physics. It's all about the proximity of the recording electrodes to the actual myocardium.
Oh, okay.
Yeah. So in a young, thin individual, there is very little adipose tissue or even muscle mass between the heart itself and the chest wall where the leads are placed.
So there's less insulation.
Exactly. The electrical signal just doesn't have to travel through all those insulating layers to reach the leads. So naturally, the amplitude of the signal is going to be significantly higher on the printout.
Wow.
The machine just interprets that strong signal as a large muscle mass, fulfilling the criteria for LVH. But in reality, the leads are literally just sitting closer to the source.
That makes so much sense, but I feel like that puts the clinician in a really tough spot. Especially when you're dealing with athletes.
Oh, absolutely. Sports cardiology is tricky.
Right, because we know that athletes undergo physiological remodeling, athlete's heart. But we also know that asymptomatic hypertrophic cardiomyopathy, HCM, is a leading cause of sudden cardiac death in that exact same demographic.
It's a huge concern.
So if a young athlete's ECG is showing this massive voltage and maybe even some weird repolarization abnormalities, how do you clinically differentiate between, oh, they just have a thin chest wall or a physiological adaptation versus, a lethal septal hypertrophy?
That's the critical question. And the answer is you have to step away from the electrical data entirely and gather anatomical data.
Okay.
You order an echocardiogram.
Right, the ultrasound.
Yeah. The ECFO can only ever suggest hypertrophy based on voltage amplitude, but the echo uses ultrasound to directly visualize and measure the actual physical thickness of the ventricular walls and the interventricular septum, like in millimeters.
So it takes the guesswork out.
Completely. It tells you definitively if there is structural pathology that's actually obstructing the outflow tract. Basically, we use the ECG to flag the anomaly, but we use the echo to diagnose the reality.
I love that. Okay, so let's apply this diagnostic framework to some of the specific cases in Hampton's book.
Let's do it.
He uses this really cool star system to rate the complexity of the tracings, and it escalates from everyday common findings up to critical code blue emergencies.
Yeah, it's great progression.
So starting right at the baseline, we have a 1-star case. This features a patient with a normal chest x-ray and an ECG showing normal sinus rhythm, but it's punctuated by frequent ventricular extrasystoles, or PVCs.
Right. And seeing premature ventricular contractions on a rhythm strip is incredibly common.
Yeah, happens all the time.
It does. And for a lot of learners, their immediate instinct is to look at those ectopic beats and consider antiarrhythmic suppression. Like, we need to fix this rhythm.
But the golden rule says.
Exactly.
Yeah.
Apply the golden rule. Look at the patient. Often, they're completely asymptomatic. They don't even feel the palpitations.
Right.
So without any underlying structural heart disease, these ectopic beats are frequently just driven by totally benign factors.
Like what, caffeine?
Caffeine, definitely. Or increased sympathetic tone, stress, lack of sleep. If the overall clinical picture is stable, those extra systoles are often clinically insignificant.
Okay, so the PVCs are basically just the everyday electrical noise of the heart.
Pretty much, yeah.
But let's look at what happens when the conduction system actually starts to degenerate.
Okay, moving up to the 2-star cases.
Right. Hampton presents this intermediate 2-star case of an 80-year-old man. He's presenting with slowly progressive dyspnea, ankle edema, and a really bradycardic pulse, like 40 beats per minute.
So he's symptomatic.
Very. And the ECG is super complex. It shows atrial fibrillation with a slow ventricular response, a left axis deviation, and a left bundle branch block, an LBBB.
That's a lot going on.
It is. So for the learners trying to visualize this, can you walk us through the actual mechanics of that left axis deviation in the LBBB? Like, how does the vector of electricity actually physically shift in this patient's chest?
Yeah, so to understand the shift, we first have to look at normal conduction. Typically, that electrical impulse travels rapidly down both the right and left bundle branches at the exact same time.
Simultaneously, right?
Right. And because the bulk of the heart's muscle mass is in the left ventricle, the dominant mean electrical vector points downward and to the patient's left.
Okay, makes sense.
Now, introduce the left bundle branch block. That rapid electrical highway down the left side is now completely severed.
Oh, wow.
So the impulse travels down the intact right bundle, and it depolarizes the right ventricle first.
Wait, so the right side of the heart actually contracts while the left side is literally just sitting there waiting for the signal?
Exactly. The synchrony is completely lost.
That sounds horribly inefficient.
It is. So what happens is the electrical signal then has to slowly spread, cell by cell, from the right ventricle all the way across the interventricular septum and finally up into that massive left ventricle.
Just diffusing across the tissue.
Right, instead of using the fast Purkinje fibers. And because this depolarization is moving in a totally abnormal direction, from right to left and often inferior to superior just to reach the lateral wall, the overall mean electrical vector is pulled sharply upward and leftward.
And that upward and leftward pull is the left axis deviation on the ECG.
Precisely. And that slow cell-to-cell spread through the myocardium is exactly what creates that wide, bizarre-looking QRS complex that you see on the paper.
That is so cool to visualize. And tracing this back to the 80-year-old patient's symptoms, this electrical detour is, like we said, highly inefficient.
Very.
The atrial fibrillation means he has totally lost his atrial kick, and the LBBB means his ventricles are contracting asynchronously.
Right, so his overall cardiac output just drops.
Which directly leads to the dyspnea and the peripheral edema.
Yes.
Like the tracing is literally showing us the mechanical failure of his aging heart.
It really highlights the progression of conduction system disease, and that actually leads us directly into the territory of the 3-star cases.
The scary ones.
Yeah, these are the critical precipice scenarios. So the text highlights a tracing showing a bifascicular block.
Okay.
Specifically, it's a right bundle branch block paired with a left posterior hemiblock. And Hampton flags this as a massive warning sign because it carries a really high risk of progressing to complete heart block.
Complete electrical failure. To really grasp why this is so precarious, I feel like we need to picture the anatomy of the His-Purkinje system.
Yeah.
Because we always talk about the right and left bundles, but it's not just two pathways. It's really a trifascicular system, isn't it?
It is, yeah. So the right bundle branch is a single distinct pathway supplying the right ventricle. But the left bundle branch, it splits almost immediately into two main fascicles.
Okay.
The left anterior fascicle and the left posterior fascicle. So essentially you have three main electrical highways supplying the ventricles.
So if we have a right bundle branch block and a left posterior hemiblock, two of those three highways are totally shut down.
Yes.
The entire depolarization of both ventricles is now relying entirely on that one single remaining left anterior fascicle.
Exactly.
That's crazy. It's literally like a major interstate highway where two lanes are closed for construction and all the traffic is being forced over a single super fragile detour bridge.
That is a brilliant way to picture it, and it's a fragile bridge that often shares the exact same compromised blood supply as the pathways that just failed.
Oh, no.
Yeah. In many cases, these fascicles are supplied by the septal branches of the left anterior descending artery. So if ischemic disease or maybe degenerative fibrosis like Lev's disease or Lenegre's disease has already destroyed the right bundle and the posterior fascicle.
Then that anterior fascicle is probably highly diseased as well.
Exactly, it's hanging by a thread.
And if that final fascicle fails,
Then the electrical connection between the atria and the ventricles is completely severed. You have complete heart block.
wow.
The ventricles might generate a slow, totally unreliable escape rhythm, or they might just stop entirely, which leads to a systole and sudden cardiac arrest.
So by recognizing that specific bifascicular pattern on the ECG, you can actually anticipate that total failure before it happens.
That's the whole point. It prompts you to prepare for transcutaneous pacing or get cardiology involved immediately. You are treating the trajectory of the disease, not just the rhythm you see in that exact moment.
Man, the conduction system is just fascinating. But as Hampton points out, it doesn't operate in a vacuum.
No, it definitely doesn't.
The heart is bathed in the patient's blood, and he makes this really compelling case for the ECG acting as a sort of systemic mirror.
I love that concept.
Yeah, where chemical changes in the body profoundly alter the electrical signature on the paper. Let's talk about that.
Well, electrolyte imbalances are probably the classic example of this systemic reflection, particularly when you're looking at the T wave.
Right.
So hyperkalemia, which is elevated serum potassium, that classically presents with tall, peaked, and narrow T waves. But hypokalemia low potassium manifests with T wave inversion, ST depression, and these really prominent U waves.
But why does potassium specifically target the repolarization phase of the ECG? Like, what is actually happening at the ion channel level to physically change the shape of that wave on the paper?
Okay, for that, it requires looking at phase 3 of the cardiac action potential.
Okay, take us back to physiology.
Right. So after the myocardial cell depolarizes and physically contracts, it has to reset its electrical gradient to prepare for the next beat.
Makes sense.
This rapid repolarization phase is driven almost entirely by the rapid efflux of potassium ions rushing out of the cell, and the speed and the slope of that efflux, that is what dictates the actual shape of the T wave.
Okay, so it's a direct reflection.
Yes. If you alter the extracellular concentration of potassium, you alter the concentration gradient across that cell membrane.
Right.
So in hyperkalemia, you have too much potassium outside the cell. That altered gradient actually causes a much faster, steeper repolarization, which is what narrows and peaks the T wave.
Oh, wow.
And then in hypokalemia, the repolarization is prolonged, which flattens the T wave and actually exposes the U wave. And that U wave is generally thought to represent the delayed repolarization of the Purkinje fibers.
It is just incredible to think that you are visually observing the altered kinetic flow of ions on a piece of graph paper.
It really is.
And this interplay between systemic chemistry and electrical function, it becomes literally deadly in case 117 from the book.
Oh, this is a great case.
Hampton presents this patient with atrial fibrillation who suddenly develops frequent ventricular extrasystoles. Now, on the surface, it just looks like the cardiac tissue is becoming irritable, right?
Right.
But the actual diagnosis requires looking at the patient's medication list and their metabolic panel. It's a case of digitalis toxicity exacerbated by hypokalemia.
Yeah. So digoxin, it's an older cardiac glycoside that we use for rate control in AFib and sometimes for heart failure.
Right.
Its mechanism of action is absolutely critical to understand here. It works by inhibiting the sodium-potassium ATPase pump on the myocardial cell membrane.
Okay.
By blocking this pump, the intracellular sodium levels increase. And that buildup of sodium reduces the activity of the sodium-calcium exchanger, which ultimately traps more calcium inside the cell, and that increases the force of the heart's contraction.
But the therapeutic window for digoxin is notoriously, like, razor thin.
Very narrow.
Where does the hypokalemia actually factor in to trigger the toxicity?
Well, potassium and digoxin actually compete for the exact same binding site on that sodium-potassium ATPase pump.
Oh, I didn't know that.
Yeah. So if the patient is hypokalemic, say maybe they're on a loop diuretic like furosemide that's wasting their potassium, there is just less extracellular potassium to compete with the digoxin.
So the digoxin just takes over.
Exactly. The drug binds much more extensively to those pumps and severely inhibits them. And this massive intracellular calcium overload leads to delayed after depolarizations.
Which are what exactly?
They're essentially these spontaneous releases of calcium from the sarcoplasmic reticulum during the resting phase. And those spontaneous releases are what trigger the early ectopic beats that you see on the strip as ventricular extrasystoles.
So if a clinician just looked at the strip, merely saw the extrasystoles, and administered an antiarrhythmic without actually checking the electrolytes in the medication history.
They would be completely ignoring the fundamental mechanism of the arrhythmia. They would basically be treating the smoke and completely ignoring the fire.
Man, that's a powerful way to put it. Treating the smoke and ignoring the fire.
Yeah.
And this concept of the systemic mirror, it reaches its absolute peak in what I think is one of the most complex cases in the book, case 148.
The zebra.
The zebra. Because in medical training, we are constantly taught the aphorism, when you hear hoofbeats, think horses, not zebras.
Right. Focus on the most likely diagnosis first.
Exactly.
Yeah.
But sometimes the patient actually is a zebra. So in this case, the tracing shows a broad, complex tachycardia. It's a highly unstable heart rate, somewhere between 130 and 200 beats per minute.
Extremely fast.
The baseline is completely irregular, and it exhibits a left bundle branch block pattern. Now, the immediate assumption would be, what, a massive primary structural heart defect, or maybe severe primary ischemia.
Sure, that would be the horse.
But the underlying etiology for this tracing was actually syphilitic aortitis.
It is such a phenomenal case study in progressive pathophysiology, because to understand it, we have to trace the destruction backward.
Okay, walk us through it.
So syphilis, in its tertiary stage, can cause this really profound inflammation of the vasa vasorum. Those are the small blood vessels that actually supply the tissue of the aorta itself.
Right.
This aortitis leads to the physical dilation of the aortic root. And as the root dilates, the leaflets of the aortic valve are physically pulled apart.
Which means they can't close properly.
Exactly. And that results in severe aortic regurgitation.
Okay, so with every single heartbeat, a massive volume of blood is being pumped out into the aorta,
Yeah.
but then it's immediately flowing backward into the left ventricle during diastole.
Precisely. So the left ventricle is now subjected to this massive volume and pressure overload.
It's working overtime.
Right. And over time, to accommodate all that regurgitant volume, the left ventricle undergoes severe eccentric hypertrophy and dilation.
Okay, I see where this is going.
Yeah, this massive stretching of the myocardial wall physically damages the electrical conduction pathways that are embedded right within it. Specifically, it stretches and disables the left bundle branch.
And there is your LBBB on the tracing.
Exactly.
So the structural collapse actually precedes the electrical collapse. But what about the atrial fibrillation that was driving the tachycardia?
Well, as the left ventricle fails and those end diastolic pressures rise, that pressure just gets transmitted backward into the left atrium.
Of course.
The atrium dilates in response to all that stretch. The structural architecture of the atrial muscle is disrupted, and it eventually just descends into fibrillation.
That is wild.
So the ECG displays this terrifying electrical storm, the rapid, irregular rate, and the wide complexes. But the root cause was actually a spirochete infection years prior that destroyed the vascular plumbing, which then eventually destroyed the electrical wiring.
It just perfectly reinforces every single lesson Hampton tries to impart. The squiggly lines in the ECG are merely the final downstream symptom of a much larger, highly complex human narrative.
Absolutely. The clinician really must act as a diagnostician of the entire systemic state. You have to utilize the ECG as just a single data point within a much broader physiological context.
So, synthesizing the depth of Dr. Hampton's 150 problems to ECG, the mandate for clinical learners is pretty clear. Right?
Very clear.
The ECG is an essential tool, but it is totally subservient to the history and the physical. Normal variants must be deeply understood so you avoid overdiagnosis. Systemic causes like electrolytes and toxins have to be considered when the electrical system misbehaves. And above all, you must respect the anatomical fragility of these conduction pathways.
Well summarized.
Thank you. And as promised for our medical learners listening, we need to test the retention of these core principles. So let's run a rapid-fire clinical scenario.
All right, listeners, put yourselves in the emergency department. You are the attending physician. A 55-year-old patient arrives with a highly concerning presentation.
Okay.
They describe the sudden onset of heavy, crushing ischemic chest pain that radiates to their left shoulder and jaw, and it's accompanied by diaphoresis.
Classic.
The pain started exactly 1 hour ago. You immediately order a resting 12-lead ECG. The tracing prints out, and it is completely normal. No ST elevation, no T-wave inversion, pristine conduction. Based on the principles we've discussed today, do you discharge this patient? Why or why not?
Well, if I'm taking this test, applying Dr. Hampton's golden rule, absolutely not. You do not discharge them.
Correct. Why?
Because in those early hours of an acute ischemic event, the myocardial cells are hypoxic and their ATP is depleting. But the cellular injury hasn't yet caused a sufficient shift in the transmembrane potential to actually alter the electrical vectors on the ECG.
Exactly.
The paper looks normal purely because the electrochemical gradients are lagging behind the physical tissue damage.
Spot on.
So you hold the patient, you initiate your acute coronary syndrome protocols, and you check those plasma troponin levels to look for biochemical evidence of myocardial necrosis.
It is a perfect application of clinical context overriding misleading electrical data. Recognizing the limitations of the tool is honestly just as important as knowing how to actually read the tracing.
Which leaves us with a really critical look forward for everyone entering the medical field today.
Yeah, this is something to really chew on. We are rapidly entering an era where artificial intelligence is becoming deeply integrated into diagnostic software.
Oh yeah, it's everywhere.
And AI algorithms are already exceptionally proficient at reading these tracings. I mean, they can identify a precarious bifascicular block or subtle T-wave changes in milliseconds with incredibly high accuracy.
It's faster than we could ever be.
Exactly. So if the machine can read the paper better than we can, it shifts the fundamental role of the physician. The true value of the future clinician won't be in memorizing voltage criteria. It will lie entirely in the domain the machine simply cannot access, the human clinical context.
Because AI doesn't see the patient.
Right. The AI can highlight the left axis deviation in a split second, but only the physician can connect that finding to the patient's aging physiology, their medication list, and their presenting symptoms to formulate a holistic, real-world treatment plan.
That's profound.
The future of medicine demands that you treat the patient, not just the printout.
The machine reads the lines, but you have to read the life. Keep pushing beyond the paper. Thanks for joining us on this deep dive, and we'll catch you next time.